Hi, good evening, everyone. So this week we'll continue with a new series. We're going to start a new series of videos from this week onwards. And this Saturday we'll start with the series on antifungal drugs. Now I asked nearly all of you what series should we start again after we have finished last week with pruritus, urticaria, and different kind of antihistamines. And majority of you voted for antifungals. So I think since this is a very important topic, but technically it's not a difficult topic. We don't have to deal with the different types of antifungals. Majorly, every one of us have their own, personal favorite antifungals, and most of the time we use them very indiscriminately. In other words, we are kind of used to in using them in a certain regimen that we have learned during our residency, and it becomes a bit difficult to learn how and when you should switch between different antifungals, and may be able to decide when you should stop giving one class of antifungals as opposed to another class of antifungals. Okay. Now, the point that I'm trying to make is that the usage of antifungals and actually a judicious use of antifungals is now a bit difficult or a bit different to understand because of the rising problem of resistance in fungal infections. We deal with patients who are suffering from dermatophytosis infections for years and months altogether, and repeated relapsing and limiting condition of the disease makes it very difficult for us to choose the antifungals. So we are not going to discuss what antifungal works best for what condition. Okay, we are just going to discuss about the pharmacology, how to use it, when to use it, and what are things to keep in mind while using certain antifungals week and week. So this week we'll start with terbinafine, and in my opinion, it's one of the good antifungals, one of the most commonly used antifungals, and so it becomes very prudent to discuss this drug this week. And I will not discuss about any different kind of regimens that you're supposed to use in different skin fungal infections. That is a purview of maybe a separate video in the future. But we'll just discuss the basic structure, pharmacology, the mechanism of action of terbinafine, so that we should know how this drug is going to change the clinical outcome of disease when we prescribe this drug to our patients. Okay. So we should know a bit about what this structure, what this chemical, what this drug is going to do when it goes inside the body, and what are things to be keep in mind. So that is the importance of learning about antifungals. So with this video, we'll just discuss the usage of terbinafine in dermatology. So let's begin. So terbinafine belongs to a class which is known as allylamine. So sequentially, every week, while we'll be discussing different classes of drugs, we'll realize that most of them they belong to certain categories of drugs. Allylamine being one, and in allylamine, the most important drug, the prototype we are going to study is terbinafine. Other classes include the triazoles or the azoles. Then you have imidazoles, and the third you have allylamine. There are other classes of antifungal agents also, and they share the common thing between these classes is that they are all used against fungal infections. Their mechanism of action can be drastically different. For example, griseofulvin, the action is over the microtubular structure, while terbinafine will act towards inhibition of squalene epoxidase. Uh, so this kind of the common link that brings all the antifungals together is their mechanism of action, is their spectrum of action against the fungal infections. Okay, so in this video, since we're discussing only terbinafine, we'll limit our discussion to allylamines. Okay, so the prototype drug for allylamine is terbinafine. Now, terbinafine got its approval in 1974, the FDA approval to be used in fungal infections. Okay, the topical 1% formulation, which is the topical terbinafine that we use, got its approval in 1992. Terbinafine is available as oral tablets, 250 milligram, white tablets, which are scored in between. And additionally, 125 milligrams is also available, but it is not that freely available in the market. So we might have to tinker or break the tablets of 250 milligram if we are using a little lesser dose in, let's say, in pediatric population. We also have granular form of terbinafine, and the doses are 125 or 187.5 milligram, a bit towards the lower side as compared to the oral formulation. They are supposed to have a larger surface area, so easily absorbability is not an issue. The granular form is easily absorbed, and because of good absorption of terbinafine in the body, it leads to a better action profile. But most of the time, I mean nearly every time when we are prescribing terbinafine, we are dealing with the oral tablet forms. Okay. So additional thing to discuss here is naftifine. Now naftifine is the first allylamine which was invented, and the only issue with that is that it is only available as a topical agent. So there is no oral naftifine. And with the subsequent modification, the naftifine, we got the molecule as terbinafine, and terbinafine is available as both as an oral agent and as a topical agent. Okay, so this could be a very good question in quizzes, or even a just a trivia to know that naftifine is the first allylamine to be synthesized. Now, when we give terbinafine, we can give it with or without food. There is no effect on absorption in the presence or absence of food. The granules, so remember that tablet is a bigger structure, while granules are somewhat smaller and they are more or less powdery. Not exactly powdery, but it's more like a coarse powder. So you just have to sprinkle on the food. Okay, just sprinkle them on the food. Okay, so you have to sprinkle them on the food, and these are helpful in dealing with the fungal infections of the pediatric population in children when they may not be able to swallow such a large tablet or a scored tablet or solutions not available. So you just sprinkle them over food. The peak level is within 2 hours. Now bioavailability is about 40%, but for granules it can range from 36 to 64%, and more than 90% is bound to plasma proteins, and the rest is free to carry out its action. The half-life is about 36 hours, and it's very variable in different articles. I have seen articles mentioning it as 16 hours and as high as 64 hours, but since Wolverton mentions it as 36 hours, we'll discuss as T half as 36 only. Terbinafine undergoes significant hepatic metabolism. Okay, so it gets rapidly converted to different kind of metabolites, and none of the metabolites of terbinafine has found to have antifungal activity. Okay, so terbinafine gets rapidly metabolized in liver, and here it is converted into different metabolites, but those metabolites are very minimally found in the circulation, and there is no antifungal activity of these metabolites. Terbinafine is an active CYP2D6 inhibitor. Okay, and what happens is that all the drugs which are being metabolized by this cytochrome enzyme, these drugs will increase, and all the drugs which increase the activity of this cytochrome enzyme will eventually decrease terbinafine. So just from a drug to drug interaction point of view, this knowledge becomes useful that terbinafine is a good inhibitor of cytochrome 2D6. Now 70% of the drug is excreted via urine, while the rest 30 to 40% is excreted through the feces. So whenever your patient would have any kind of renal or hepatic impairment, if the livers and kidney are not functioning properly, you should decrease the dose of terbinafine by 50%. It's a good idea to decrease the dose in patients who have renal impairment, like if you come across a patient who is on dialysis for chronic kidney disease, you cannot use the higher drugs of 250 milligram a day. It's a good idea to decrease the dose to a lower end, or at least start and monitor the KFT values, see if the creatinine or urea rises, and then you may decide to give a higher dose if required, if clinically it is required. Otherwise, you should have a 50% dose reduction in patients who have liver and kidney impairment. Now this diagram I've taken from this book on page 115. So if you want to read more about it, you can get access to this book and read. And this diagram is supposed to summarize the action, the area or the point of action of different antifungal agents. And we are going to limit our discussion only to allylamines in this video. So allylamines majorly acts on the cell membrane level and disrupts the synthesis of ergosterol. Now remember, ergosterol is a cholesterol molecule which is required by the fungus to make its own cell membrane. Okay, and if that metabolism, or rather than synthesis of ergosterol, is disrupted by any of the drugs, the fungus will not have the raw materials to build its own cell membrane, and because of that the fungus stops growing. So depending on the damage to the cell membrane, depending on how much we are able to disrupt the formation of cell membrane, we can say if the drug is fungistatic or fungicidal. So fungistatic, okay, so let me just write it down. Fungistatic means that it will stop the growth of fungus. So it will stop the growth of fungus. While fungicidal means it will kill the fungus. So it will kill the fungus. Okay, so depending on the disruption to this fungal cell membrane, we can say that this drug is fungistatic, or this drug is fungicidal, or even you may have one drug being fungistatic on different fungal species and being fungicidal for different fungal species, depending on their dependence of individual species on ergosterol incorporation in their cell membrane. Okay, so the level of dependence of ergosterol in formation of cell membrane decides whether the drug which is disrupting the synthesis of ergosterol will lead to fungicidal action or fungistatic action. Am I clear on that? So this diagram will keep on seeing in every week lectures while we're discussing individual antifungal agents. Okay, let's move forward. So we have discussed about the somewhat of a short introduction on the action of antifungals, and since we're discussing terbinafine in this video lecture, the action of terbinafine is the disruption of ergosterol synthesis and thereby disrupting the cell membrane of the fungus, and that is how the fungus growth is stopped by terbinafine. Okay, so let's discuss the pharmacology or the function or structure or how this drug is going to behave inside the body. Okay, so terbinafine shows high keratin adherence and lipophilicity. Now remember, the stratum corneum is made up of various keratinocytes interlacing, and in between, let me just change the color a bit darker. Yeah, in between you have cholesterol, free fatty acids, and all sorts of things. Okay, and this is just a second. Yeah, and this is known as brick and mortar model. So the keratinocytes or the corneocytes are the bricks, and they're stuck together with cholesterol, and that cholesterol is mortar. Okay, so terbinafine shows high adherence to these keratinocytes, so it sticks to these keratinocytes, and since it has high lipophilicity because of the lipid nature of in between the keratinocytes, it gets easily migrated and stays in the skin. So that's how terbinafine is helpful in management of fungal infection of skin and nails, because it's easier for it to go there and stick. Okay, it reaches the stratum corneum through three mechanisms. The major one is through sebum, that means through oil. Remember, it is highly lipophilic, it loves fat. So, because of secretion of fat over the skin, which is in the form of sebum, the terbinafine reaches from the blood circulation to the skin. And levels as high as 50 times the plasma levels can be achieved in sebum. Okay. So traveling through sebum becomes the major pathway of terbinafine to reach the skin. Other minor pathways are diffusion through dermoepidermal junction. So we all know that we have the dermis, we have the epidermis, okay, and here the blood vessels end. So there can be a passive diffusion from the blood vessels towards the epidermis, and that is one of the minor pathways of traveling of terbinafine. Additionally, migrating basal keratinocytes can also contribute for terbinafine to reach. For example, the terbinafine comes from the blood vessel to the dermoepidermal junction, and because of high keratin adherence attaches to the basal keratinocytes, and while the basal keratinocytes are slowly moving over a skin cycle of 28 days, the basal keratinocyte reaches the topmost layer and carries terbinafine along with it. Okay, the minimal inhibitory concentration is reached within hours in the skin, and within 2 days it can easily be reached in sebum. The elimination half-life is about 3 to 5 days. That means the drug stays in skin and sebum for the next 3 to 5 days. Okay, and the books mention that the usage of terbinafine in the dose of 250 milligram once a day for 12 to 14 days, roughly about 2 weeks. When you use it more than 12 days, the elimination half-life is actually extended That means the longer the duration of intake of terbinafine, the longer it's going to stay in the system, and that is the explanation given that many a times when you stop terbinafine, the mycological cure or the disease cure or the clinical efficacy is still going on even after stopping the drug, at least for few 1 or 2 weeks. And the reason for that is that if you take for a longer duration, the drug stays in the skin level or the sebum level for a longer duration of time, for an increased day of time. Okay. Additional point to mention is that terbinafine has not been detected in eccrine sweat. Eccrine sweat. Now remember that apocrine and eccrine sweats are two different kinds of sweats, and apocrine has a little bit more of free fatty acids and fatty molecules. And since terbinafine is lipophilic in nature, it is easily found in the apocrine sweat, and it has not been found in the eccrine sweat. Eccrine sweat being more watery. Let's discuss the pharmacology of terbinafine in nails. So, terbinafine is drug of choice or the FDA approved drug for tinea unguum or the dermatophytic infections of nails. So, we need to know a little bit about the pharmacology of nails. So, terbinafine is detected within 1 week at the distal most part. So remember that this is, let's say, your nail plate, okay, and this is the finger, okay. So, the distal most part, this edge, terbinafine is detected in within 1 week, and that is because it diffuses into the nail plate via the nail bed and the nail matrix. Okay, so remember in this very crude and very simple diagram of the nail apparatus, we can see this is the nail matrix. Okay, and just the skin beneath the nail plate is the nail bed. Okay, this is the nail plate. So terbinafine diffuses from the nail bed upwards into the nail plate and also through the matricial cells, the cells of the matrix, and it is detected within 1 week at the distal most portion of the nail. Okay, and the concentration achieved in the nail is roughly about 10 to 100 times the minimal inhibitory concentration of most dermatophytes. So the minimal concentration of drug required to stop the growth of dermatophyte, the levels in the nail is about 10 to 100 times more of that. Okay, that makes terbinafine a very good drug for tinea unguum, okay, or the dermatophytic infections of the nail, and that is why it is the FDA approved drug for that. In the hair, terbinafine is detected within 1 week of starting therapy. The delivery is majorly through sebum, like we see in the skin, and also on the hair matrix cell, like we see in nail. Okay, drug accumulates preferentially in the hair shaft. Okay, so the drug accumulates inside the hair shaft, and that is why terbinafine is very effective against tinea capitis caused by endothrix organisms. So just a short reminder that you have nail, and if these spores are inside the hair shaft, it is endothrix. If the spores lie outside the shaft, it is ectothrix. Ecto and endo. And we have said that terbinafine is accumulated inside the hair shaft. So that means the action on the spores which are situated inside the hair shaft will be more, okay, as compared to the action on the spores outside the hair shaft. Okay, that is why terbinafine is very effective in tinea capitis or the infection of the scalp and the hair shaft when it is caused by an endothrix organism. For example, the examples include Trichophyton tonsurans. Okay, so Trichophyton tonsurans predominantly is an endothrix organism. It infects the shaft from the inside, and because of that, the action of terbinafine is more on the endothrix organisms. Compare that with ectothrix infection. Ectothrix means the spores are outside the shaft. The examples include Microsporum canis. Okay, so Microsporum canis is an ectothrix fungi, and the drug which will act better on ectothrix would be griseofulvin. So it's a good idea if you're dealing with a pediatric patient with tinea capitis, just pluck some hair, look under the microscope, see if it is ectothrix or endothrix, and either give terbinafine or griseofulvin. Okay. But if you're giving terbinafine for a ectothrix organism, you might have to, increase the duration to 2 times. so that the level of drugs that are reached at the hair level should be high enough, significant enough to kill the fungi. Clear? So we have discussed the specific pharmacology, the pharmacokinetics when dealing with the terbinafine in skin, terbinafine in nail, and terbinafine in hair. Let's discuss in briefly about the mechanism of action. How does terbinafine actually kill, not kill per se, but actually manages these fungal infections of various skin appendages and the cutaneous skin infections also. So the mechanism of action is non-competitive inhibition of the enzyme squalene epoxidase. Now this squalene epoxidase is a very important enzyme in the formation of ergosterol. And remember, we have told you that ergosterol is a very important molecule incorporated into the cell membrane. Okay. So when the fungus is not able to get good amount of ergosterol because of terbinafine, it stops growing, and that is why the action is more fungistatic. Okay, so when during the whole process of formation of ergosterol, we'll look at the process in detail in the next slide. And during the whole process, squalene is converted to ergosterol, and in many of those steps, one of those steps is catalyzed by squalene epoxidase. Okay, and when this gets blocked by terbinafine, squalene is not able to convert better into ergosterol. There will be decreased ergosterol, leading to fungistatic nature of terbinafine. Now when squalene epoxidase is blocked, is inhibited, is non-competitively inhibited by terbinafine, the level of squalene rises. Okay, so you have increased amount of squalene. Now this increased amount of squalene can actually get incorporated into the cell membrane and can increase the permeability of cell membrane. So it increases the permeability, and when the fungal cell membrane becomes very permeable, the cell is not able to hold its place and eventually it dies. And because of the cell death, the action of fungicidal nature of terbinafine is there. So the major mechanism initially was thought to be deficiency of ergosterol leading to fungistatic action, but new studies say that accumulation of squalene increases the cell membrane permeability of the fungal cell, leading to a more fungicidal action. Clear? Now this is the formation of ergosterol. Where is ergosterol? Yeah. So this is ergosterol starting from acetate. So from acetate we'll get squalene after multiple steps. From squalene after multiple steps it will form lanosterol, and one of those steps is catalyzed by squalene epoxidase. Here, from lanosterol, by the action of 14-alpha demethylase, it gets converted into 14-alpha demethylanosterol. And then subsequent multiple steps later, this molecule forms ergosterol. Now this ergosterol is needed for fungal cell membrane synthesis and fungal cell replication. We are clear on that? We'll start with acetate, form squalene after a lot of steps. Under the action of squalene epoxidase, we'll get lanosterol eventually. Lanosterol under the action of 14-alpha demethylase will form 14-alpha demethylanosterol. And 14-alpha demethylanosterol after multiple steps will form ergosterol. Ergosterol is required for the formation of good amount of cell membrane for the fungus and fungal cell replication. Now what terbinafine does, or the various other allylamines like naftalin, what they do is they non-competitively inhibits this enzyme squalene epoxidase. Okay, and because of blockage of this squalene epoxidase, the ergosterol concentration eventually decreases and the fungus is not able to form its cell membrane. Apart from that, when cell membrane synthesis is blocked, there is accumulation of squalene. Okay, there is accumulation of squalene, and because of the accumulation of squalene, the fungal cell membrane will increase in permeability, leading to cell death. So this part of the mechanism is fungistatic, while this part, the squalene part, is more of fungicidal. Clear? Okay. So we have discussed the mechanism of action of terbinafine, majorly deficiency of ergosterol and accumulation of for squalene. Now, this accumulation of squalene leading to increased cell membrane permeability is mostly seen in vitro studies. Whether it is important for the in vivo action or the action in human beings or living organisms is yet to be concretely said, but it does leads to in vitro studies it has been shown that accumulation of squalene does lead to fungicidal action or disruption of the cell membrane in view of its increased permeability. Okay, so that is when you are discussing the mechanism of action of terbinafine in your viva or something, it's a good idea to mention that because of increased accumulation of squalene there is increased cell permeability. Now, terbinafine is FDA approved for treatment of two disorders. We have onychomycosis, or specifically tinea unguum of of the nails, and then we have tinea capitis. Okay, in tinea unguum, so it's a very common viva question that what is the difference between onychomycosis and tinea unguum. Now, onychomycosis, onycho means nail, so onycho means nail and mycosis means infected by fungus. So whenever nail is infected by fungus, it is onychomycosis, and that includes all the nail infections caused by fungi. For example, Candida can cause onychomycosis. We can have aspergillum can cause onychomycosis. Even histoplasma can cause onychomycosis, and so all of these are known as onychomycosis. But if it is caused by dermatophyte, okay, for example, if trichophyton mentagrophyte, trichophyton rubrum is causing onychomycosis, then that specific group of disorders are known as tinea unguum. So you have a large subset of onychomycosis and a little subset of tinea unguum. So this is tinea unguum and this is onychomycosis. So whenever you have a case of onychomycosis not responding to terbinafine, you might want to culture these nail scrapings and find out whether you are dealing with a non-dermatophyte nail infection and then change your dose accordingly. So the regimen mentioned is 250 mg once a day for 6 to 12 weeks. 6 weeks is when you're dealing with fingernails. 12 weeks is when you're dealing with toenails. Okay. For tinea capitis, it is FDA approved for use in more than 4 years of age only. Okay. And it is superior for the treatment of T tonsilline because this is an endothrix infection. We have discussed that in detail in previous slides. And so it is better than glycofulvin. Now remember, glycofulvin is drug of choice for tinea capitis. But if the infection is endothrix, you may consider using terbinafine. For non-dermatophyte infection, it does show some activity, but the MICs are lower. MIC means the amount, the concentration minimally which is required to kill the non-dermatophyte infections. The level of terbinafine that is reached in nails is actually lower. If you are dealing with a non-dermatophyte infection, you might have to use a higher dose or a longer duration to have that kind of clinical efficacy. Okay, when you're dealing with non-dermatophyte. For dermatophyte, it's okay. That then it means you're dealing with tinea unguum, and you can use terbinafine easily. Now, on the basis of action, terbinafine has found to be fungicidal for other fungus, which are the non-dermatophyte fungus here. These include Aspergillus fumigatus, Blastomycosis dermatitis, Histoplasma capsulatum, Scopulariopsis brevicollis, Sporothrix schenki, and Candida parasilosis. It has been found to be fungistatic against C. albicans, Candida albicans. But it's a good idea not to use terbinafine while dealing with non-dermatophyte nail infections. It's important that you switch to either itraconazole pulses or that, uh, or maybe some kind of topical cyclopyrox lotion or solution or that sort. Uh, However, in clinical practice, we don't usually get fungal scraping checked for cultures. Okay, we usually do it for KOH and try to find out if we can delineate between different types of fungal species. But I personally use itraconazole pulses for onychomycosis rather than using terbinafine. But if it is caused by a dermatophytic fungi, then terbinafine is good enough drug to use. So two major trichophyton species, Trichophyton mentagrophyte and Trichophyton rubrum. Terbinafine has good action against these species. So whenever dermatophytic infection, and we are talking about tinea cruris, tinea corporis, okay. So this tinea gluteal is one thing that I read. So for cutaneous dermatophytic infection, terbinafine is shown to be very active against species like Trichophyton mentagrophyte and Trichophyton rubrum. Okay. In vitro, in vitro efficacy has been shown against Candida albicans, Epidermophyton flocosum, and Scopulariopsis brevicolis. So, in vitro action has been found against these fungal species. But if you are dealing with Trichophyton mentagrophyte and Trichophyton rubrum, terbinafine is good enough drug to start. Now, for onychomycosis, 5 to 10% solution is available which you can apply in and around the nail. So, let's see if this is the nail. So you can apply the solution around the nail folds, and what I tell my patient is to separate the skin from the nail. For example, if you see the finger vertically, just separate this a bit and put one drop inside the nail and nail the just between the nail bed and the nail plate so that it diffuses at the site of action. So the solutions available is 5 to 10%, but right now I think the most commonly available is actually 1% liquid formulation of terbinafine, and that can be used if you're trying to use terbinafine topically for nail infections. Some definition that you should know is mycological cure, effective treatment, and clinical cure. Okay. So mycological cure means that KOH is also negative. So for example, if you have a nail infection, let me just adjust this. Okay, so let's say if you have a nail and you have the onychomycotic part of the nail, and you do a KOH and it comes out to be positive for dermatophyte, and culture also comes out to be positive for dermatophyte. You keep on treating the nail till this KOH or this culture becomes negative, and when both of these become negative, you can say that it is mycological cure. Okay, so why do we have different kind of definitions? Okay. The reason we have different kind of definition is that nail infection, the fungus might die because of your treatment, but it can still show clinically those fluffy yellow deposits underneath the nail. Okay, so that deposits can be there. So even if the culture from the deposits show negative on KOH and negative on culture, the term that we use is mycological cure. That means the fungal infection is cured. Okay. Other definition is effective treatment. By effective treatment, we mean mycological cure, that means negative KOH. Just a, yeah. Mycological cure, that means negative KOH and 0% nail involvement or more than 5 millimeter of new unaffected nail growth. And usually I use this parameter to judge whether the fungus is showing improvement. Okay. So you should have at least more than 5 millimeter of new unaffected nail growth along with mycological cure to say that the treatment has been effective. Clinical cure means there is 0% nail involvement. That means there is no fungus, no KOH, no culture, and no deposits underneath the nail. The nail is perfectly fine clinically and they are perfectly normal. Okay. So in various studies that I could find, I could find that mycological cure is seen in roughly 70% of patients, effective treatment in 50%, and full clinical cure in 30% over varying durations of treatment. Other studies mention that mycological cure roughly about 70%, the same, effective treatment on the higher side by 70%, and clinical cure in 50% of patients. So these are different kind of studies, but it's a good data to quote in your viva that 70% achieve mycological cure, 50% achieve effective treatment, and 30% achieve clinical cure with 0% nail involvement. Let's discuss topical terbinafine shortly. It is available as 1% cream formulation. Once a day application is what is recommended. The half-life is about 14 to 35 hours. Remember that oral terbinafine has half-life of about 36 hours. 75% is eliminated in urine in metabolized forms. Improvement does continue after discontinuation because of high keratin adherence and high lipophilicity. The adverse effects reported, now most of the time it is well tolerated, okay, but most common adverse effects are irritation at the site, which is roughly seen in 1.5% of patients, increase in itching in 1% of patients, discoloration at site, and even contact dermatitis to terbinafine. Okay, so you can have contact dermatitis to terbinafine. You can have contact dermatitis to all the other agents which are mixed in the cream. They can be excipients, cream base, or preservatives to increase the shelf life, or fragrance molecules. Okay, so a person showing reactivity to terbinafine cream might still be okay to use terbinafine in the oral form when you have suspected the contact allergy to the additional agents rather than topical terbinafine. Okay, there have been one case, I remember I was treating one case who had irritation with topical terbinafine, and I switched to oral terbinafine, and he had intense drug induced maculopapular eruption. So I came to know that he is allergic to terbinafine, but see, mostly when there's a contact allergy, I suspect preservatives and fragrance molecules if I'm not suspecting the major drug. But on shifting to oral drugs, he had an intense generalized maculopapular eruption, and because of that, I came to the conclusion that the drug allergy was to terbinafine, not the excipients. So we must keep that in mind. So it's a good idea to change the entire class of drugs, not the route of administration, but the entire class. That would be much more understandable and helpful. Quickly, we're going to discuss about the off-label uses of terbinafine. Now, remember that terbinafine is most commonly used in skin dermatophytic infections like tinea cruris, corporis, and others. The FDA approval is only for tinea unguam and tinea capitis for ages 4 years and above. But these are the off-label uses of terbinafine. So quickly, we'll discuss that. Off-label use, terbinafine can be used as an off-label indication in children. In children, you have weight-based treatment. However, the oral treatment is not approved, but you have to change the dosages depending on the weight of the child. If it is less than 20 kg, the dose is 62.5 milligram. If it is between 20 and 40 kg, the dose is 125 milligram. And if it is more than 40 kg, you give the adult dose of 250 milligram. Okay. So what I usually advise is, if I don't have access to oral solution, is to break the tablet into fourth. So one tablet is 250 mg, and when you break it in fourth, you get 62.5 of each quadrant. 62.5 each quadrant. So you just break it into half, then another half, dissolve it in little water in a spoon, and feed to the child if you are not able to access the oral solution. Now, other dermatophytic infection like tinea infection, tinea corporis, tinea cruris, I've already said this, these are off-label indications. In non-dermatophyte, you can use terbinafine, but the data is limited and you have to use a longer duration and a higher dose. It is less effective against candida. This is a very important, or you could say a very good viva question. I've been asked antifungal agents who are active against candida but not active against dermatophyte, and antifungal agents which are active against dermatophyte but not candida. So terbinafine and allylamine is the answer to the second question. The answer to the first question we will learn when we learn individual antifungal drugs every week. Other deeper fungus like Aspergillus, porotrichosis, these are also off-label indications. Seborrheic dermatitis. Now, I found one article which mentioned 250 milligram once a day for 4 weeks, but seborrheic dermatitis of the face may not benefit. And this is when we are considering the implication of Malassezia furfur in the triggering of seborrheic dermatitis. So when this fungus is implicated, you can use terbinafine, but most of the time, I don't use antifungal agents to treat seborrheic dermatitis, maybe ketoconazole in a few of the cases, but terbinafine has been used as an off-label indication in the dose of 250 milligram once a day for 4 weeks. And then we have the deeper fungus again, along with Aspergillus and porotrichosis. We have histoplasmosis, and chromoblastomycosis. But you have to use a higher dose of terbinafine and a longer duration of terbinafine. Okay, so we have learned about terbinafine structure, pharmacology, mechanism of action, FDA approved uses in tinea unguam, uses in tinea capitis, and off-label uses of terbinafine. Now we'll discuss about the side effect profile and the adverse effect profiles of terbinafine. Most common side effect is headache. Patient also complained of nausea, diarrhea, and gastric reflux. The important side effect is hepatotoxicity or liver damage or transaminitis. Hepatotoxicity can be subclinical. That means patient might not have clinical symptoms, but SGOT and SGPT values might be raised. So it's a good idea that if your patient has any risk factors for hepatotoxicity, let's say they are alcohol dependent or they are taking additional other drugs which are hepatotoxic, or they have just recovered from acute liver failure or something like that. If you suspect that the liver function might be compromised, it's a good idea to get a baseline LFT done. Okay, get a baseline LFT done, and it's a good idea to monitor the liver function test at least for the first 4 to 6 weeks. Okay, the hepatitis because of terbinafine occurs in within 4 to 6 weeks of starting the therapy and is seen within 3 months. Okay, so the liver damage, the hepatotoxicity is seen in 4 to 6 weeks to 3 months. So it's a good idea to monitor your patient, the liver status of your patient while giving terbinafine for these longer durations of treatment. Okay, the liver damage is seen in both forms. That means you have hepatocellular necrosis, that means damage to individual hepatocytes, and cholestatic injury, that means damage to the biliary radicals leading to bile accumulation and further damage to the liver. The hematological side effects include lymphopenia, that means decrease in lymphocytes, and neutropenia, that means decrease in neutrophils. So much so that less than 1000 cells per millimeter cubes of neutrophils means that you have to stop the drug. Okay, so if the neutrophil count, the absolute neutrophil count is less than 1000 cells per millimeter cube, you have to stop the drug. Clear? Additional side effects include dysgeusia, that means altered taste, anosmia, that means altered smell or no smelling, and these side effects can be long lasting, can even be permanent. In case your patient is complaining of these kind of side effects, increased taste disturbance, increased smell disturbance, increased symptoms of liver damage, you have to stop the drug. You have to discontinue the drug. Depression has also been reported in one of the in some of the articles. So you have to keep asking questions, so that if there's even a slight hint of depression, you ask leading questions. Maybe you have to stop the drug. If it is significant, take psychiatric help. Do suggest psychiatric intervention. Rare side effects include psoriasis exacerbation, LE-like lesion. In fact, there has been one case report of dermatomyositis-like presentation of terbinafine toxicity. Acute generalized xanthomatosis papulosis is a very important side effect, clinically important for the outcome of this side effect. We are not going to discuss HF in detail in this video. Maybe in future, if people want to learn about HF, you just post that in comments. If I get significant comments, I might make a short video on HF. Fatal side effects or serious side effects like anaphylaxis and SGSTEN has also been reported. Even I think there's a case report of Dress syndrome with terbinafine. Tinnitus and hearing impairment is also reported. Any of these side effects, if it is cumbersome, if it is causing issues to the patient, stop the treatment. Contraindications to terbinafine include any hypersensitivity to terbinafine or the components of the formulation like any other drug, or if the patient has chronic or active hepatic disease. In fact, it is mentioned that if your patient comes from an area where hepatitis is endemic, you should get an Hep C and Hep B level done also. Screen for Hep C and Hep B infection. You might be dealing with a subclinical hepatitis. So we should be careful on those lines of things. There are no box warnings per se, but the certain warnings that they mention is hepatic. For example, hepatic means they have been cases of hepatic failure. Failure so severe that the patient required liver transplant, or even fatalities have been reported because of liver damage. Hematology, we have already discussed. Lymphopenia is there. Thrombocytic microangiopathy has been reported. Okay. Smell disturbance, taste disturbance have been recorded. Hypersensitivity reaction like LE-like reaction, DM-like reaction, SLE, SGSTN, anaphylaxis, everything has been reported. Few rare cases of depression have been reported, so we must be on the lookout for these kind of symptoms, okay, while using terbinafine. Now, drug interactions are important. We have already mentioned that terbinafine is a good inhibitor of CYP2D6 enzyme. So, all the drugs which are metabolized by these enzymes, it is important to know if your patient is on these kind of drugs or not. Now, drug interactions are very important to understand, especially in the event of polypharmacology or polypharmacotherapy when your patient is taking drugs for different disorders also. So narcotics, all members are substrate for cytochrome enzyme 2D6, and that the in conjunction with terbinafine, which inhibits CYP2D6, the levels of narcotics might increase. Okay, so we have to keep that in mind. Same for beta blockers. Same for tricyclic antidepressant and antipsychotics. Now remember that 2D6, D for depression, that is just to remember. Okay, D doesn't mean depression. We are just remembering. So 2D6 means D for depression. That means psychiatric issues. That means all the antipsychotics, CNS depressants, all the tricyclic antidepressants, beta blockers that depress the anxiety and everything. All of these drugs which are used to treat psychiatric disorders are a substrate for CYP2D6, and when it is inhibited by terbinafine, you might find the levels of these drugs rising in the system, leading to side effects. Clear? Other drug interactions include NSRI antidepressants, SSRI antidepressants, antidysrhythmics like amiodarone. Okay, we have HIV protease inhibitors like ritonavir, antipsychotics. So remember, all the psychiatric drugs, all the psychotic drugs are substrate for CYP2D6 and can have interaction with terbinafine. Lower drug interactions have been reported with anticonvulsants, rifamycins, other antifungals. We should not combine antifungals. I usually combine topical with oral. I think I've given terbinafine with itraconazole in 2 or 3 patients together. But I do believe in switching the drug class when I see no response or minimal response. Okay, so I do tinker around with drugs, but I don't usually give 2 different classes of oral drugs together. Okay. Now, one thing to remember that drug clearance of cyclosporin is reduced by 15%. Cyclosporin excretion is reduced by 15% if the patient is taking terbinafine. If the patient is taking rifampicin for any of the indications, the terbinafine clearance is increased. The terbinafine, okay, let me just write it here. Rifampicin increases the clearance of terbinafine by 100%. Remember that rifampicin is a very potent cytochrome enzyme inducer. And when the cytochrome enzymes are induced, they are more active because of rifampicin. Remember that terbinafine undergoes extensive hepatic metabolism and that it gets metabolized to its various constituents. And that is why terbinafine dosages or the effect might decrease. Okay, so keep that in mind. So this one is a short slide. It's pregnancy category B. And in lactation, it has been found that milk to plasma ratio is 7:1. And it is excreted in milk. And it is not recommended in lactating mothers. Okay. Whether the level of terbinafine in breast milk is significant enough to cause any kind of side effects in the baby or the neonate, that is yet to be seen. They are not very much conclusive data. But in the absence of data, you need to weigh the pros and cons, the benefit and the risk profile of terbinafine while giving in a mother who is actively breastfeeding her child. So we just have to, use it in special circumstances. But remember that the pregnancy category is B. It's safer in giving terbinafine in pregnancy. Now monitoring is simple. You monitor LFT for 3 to 4 weeks. You remember that the liver damage occurs in 4 to 6 weeks within 3 months. So it's a good idea to monitor. CBC if the treatment duration is more than 6 weeks. Terbinafine can lead to lymphopenia and neutropenia. So just monitor CBC levels if the treatment duration is more than 6 weeks. Monitor for other symptoms like dysgeusia, depression, rash. You may have to discontinue drug. So just one slide regarding the resistance. Resistance is the bane of antifungal treatment in the current day and age. Okay, and we must know a little bit about resistance so that we are able to first of all answer questions in a viva. Second of all, learn about or suspect about the resistances to terbinafine. And most of us believe that terbinafine is highly resistant, the fungal species are highly resistant to terbinafine. But the articles mentioned that initially when terbinafine was used, it was a very good drug. Then because of the development of resistance, the terbinafine was, somehow went out of favor, and now it is somewhat returning back into the treatment regimen. So this is not at all an advice to fellow dermatologists to start using terbinafine while treating dermatophyte infections. But you may consider terbinafine when itraconazole or other azoles or other drugs are not showing the adequate response. Okay. So the mechanism of action is roughly three types. The most important is the SQLE or squalene epoxidase enzyme mutation. So you have point mutation in the major enzyme that is blocked by terbinafine, and when that mutation occurs, the drug is not able to bind to the enzyme and the inhibition doesn't take place and the fungus is resistant. There can be overexpression of SAL A gene. Now, SAL A gene encodes for salicylate 1 monooxygenase, and what this enzyme does is it destroys naphthalene rings. So, if you look at the structure of terbinafine, you have two rings attached together. These are the naphthalene rings, and then you have a long chain. And this ring part is destroyed by salicylate 1 monooxygenase, thereby destroying the drug. So, when you have overexpression of SAL A gene, you have increased destruction of terbinafine, conferring resistance to the fungal organisms. There can also be overexpression of efflux pumps. So what efflux pumps does it? It throws out the drug from the cell to the outside environment. So when there is overexpression of efflux pumps, terbinafine is actively thrown outside the cell. Okay, so mechanism 2 and 3 are the minor mechanism. The major mechanism is still the point mutations at the drug binding site of squalene epoxidase. Clear? So just remember these few words. You'll be easily able to write enough about resistance to terbinafine in fungal infections. Now with this, I'll end my presentation. It's already quite long on just one single drug. If you want to know more about the drug, I would highly recommend to read the product drug insert. You need to learn a lot about drugs. Read the product drug insert. It's freely available on the internet as a PDF file. You can easily search and download and read. I found two good articles. This comparative efficacy of continuous and pulse dose terbinafine regimen in toenail dermatophytosis. It's a good article. You should try to get access to the full text and read full text. It's a very good article. Other article is Terbinafine, a pharmacological and clinical review. It's a bit older, 2009, roughly about 14 years back. So, but it's a good review. So, if you want to learn more about the usage of terbinafine, you want to know more about terbinafine, read this article. If you want to know about tinea unguum and the action of terbinafine in tinea unguum, read this article. These are good articles. Get access to it. I'll of course put the URL in the description. Okay, so with that, I've finished this week's lecture. We have discussed terbinafine. We'll return again next week and discuss another antifungal. The idea is to discuss each and every antifungal individually. Okay, I don't want to club antifungals together. I don't want to discuss all the azoles together. I want to make videos on individual drugs so that you have to just see one video to discuss about one drug. Okay, most of the books club them together. Most of the groups either discuss azoles together and then go into few separate points. That's a good idea on to kind of to discuss these drugs. But I think discussing individual drugs are important because most of the time you are not going to use all the antifungals for different indications. You will have, for example, if I want to treat fungal nail infections, I give itraconazole. If I want to treat intertrigo, I give clotrimazole. If I want to treat antifungal tinea corporis cruris, I prefer either terbinafine or itraconazole. I don't go for griseofulvin. If I want to treat tinea capitis, I go for griseofulvin. So every one of us have our favorite antifungal for favorite or separate indications. So we need to know in detail about separate antifungals so that we can make a conscious and a better decision regarding the use of antifungals in fungal infections. Okay, so with that, this video is finished. I would like to thank you if you have made it to the end. Okay, Any comments can be posted just below this video. I read and reply to all my comments. You can email me separately if you want, or you can just mention how we can improve this series. I know the videos are long, but this is the only source you require to learn about terbinafine. So with that, I'll end this video. Adios, amigos. Bye bye. Enjoy your weekend. Tada.